I'm gonna get started. I might not be able to see the chat box, so throughout the um lecture, there's gonna be like some discussions that I just kind of want to have. So please feel free to unmute and we can kind of start talking about things. All right. So this is part of one of the series on documentation malpractice in the ED. More than 75% of emergency physicians will be named in a malpractice lawsuit at least once throughout their careers. And a lot of times we could have done everything right by the patient and by us, and it still happens. But practicing good medicine and documenting the care that you provide effectively and accurately can help us avoid bad legal outcomes that follow us for what seems like forever. Documentation issues are thought to play a role in up to 20% of these lawsuits. So that means one practice cases is due to poor documentation. And guess what? Documentation is in our control. So while poorly written documentation doesn't irrefutably prove malpractice, it can significantly weaken a physician's defense and it can strengthen a plaintiff's case. So poor documentation can undermine credibility, make it difficult to prove what was done, and then suggest a lack of care. As much as it feels like a chore to have to write a note, I really want to emphasize how important this is and how much it's actually a part of the care that you're providing to your patients. And also, it's a legal document. I want to walk you through a case today that left a patient with severe, permanent, life-altering changes, and the case went to trial. This isn't to scare all of us. It's really just to remind ourselves that this can happen to anyone. The lens that I want you to approach this talk with is when I'm faced with something similar in the ED, how am I going to approach it based on what I'm seeing today? Am I going to do the same thing? Am I going to document differently? Am I going to do something differently? If so, how and why? I'm going to be asking some questions as we go through the case to build some dialogue around this and talk about how we can do better. Or maybe we're all doing amazing and we just have to keep doing the same thing, but I definitely want to hear what people have been doing so we can learn from it. And then I'm going to be pulling up some MDMs as well. So I might ask a resident to just kind of read it out loud. All right. So this is a case of a 36-year-old male who presented to the ED after having several previous visits in the past few days. He had one urgent care visit and 3 ED visits during which the true cause of his symptoms was not diagnosed. So March 25th, he went to an outside urgent care, and at that time he was having a fever for about 2 weeks, dry cough, body aches, no sick contacts. In the chart, there's no record of any workup. The documentation was mostly through check boxes without any significant narrative portion. So I just circled the narrative portion that we have here from the nursing that says dry cough, fever for 2 weeks, last Advil at 11 today. And then the physician wrote mainly dry cough. And then this was essentially the MDM. Does anybody have thoughts on this? Good, bad, anything else you would have written? Feel free to like unmute yourself, share your thoughts.
Well, it doesn't really give much of an MDM at all, really. It's just saying what he did and the dispo. So I think it needs a lot more.
Yeah, exactly. So then on the discharge instructions, for this urgent care, there's a bunch of like boxes based on the complaint that the patient presents with. So they made a bracket around bronchitis, asthma, and then at the bottom they wrote Tylenol every 4 hours, ibuprofen every 6 hours, 8 hours, it's hard to tell, for fever. Any thoughts on this?
There's no return precautions. There's no like notation for follow-up that this person might need.
Yeah, Sierra, exactly. There's no return precautions. There's no contingency plan for what to do next, no time frame about anything. So those are some things that stood out to me too. So unfortunately, this patient's symptoms continued and he followed up in an emergency department 2 days later. He was still having a cough and a fever. Now he has neck stiffness and back pain. He had some urinary discomfort that he says is getting a little bit better. And he reported having a metallic taste in the mouth, some slight blurred vision. The documentation also notes that he saw another physician in between the urgent care and this ED visit, but it wasn't a part of the court records. So, as this was technically his third visit to a healthcare provider for this illness, a more thorough workup was done. I just wanted to bring up some pertinent negatives and positives from the patient's exam that was documented. It was documented that he's non-toxic. He has pale, decreased skin turgor, mild meningismus, reproducible left paralumbar tenderness, moving extremities well, negative straight leg raise. So the patient received fluids, Tylenol, Dilaudid, Zofran, and then it said in the note in the MDM that the patient after the medications has better color in his skin, the fever came down. How do you all feel about this so far? What's on your differential? Is there anything else that you would have done for this patient?
I think this is a patient that I would like probably fight in the ED to do an LP
Mm-hmm. Yeah,
because he has some pretty concerning signs. 2 weeks is a very long time to have fever for, and non-toxic sounds like it might be. I mean, I didn't see the patient, but it sounds inconsistent with the the story that's been created so far.
yeah, right. Like the math is not mathing. It seems like there's some sort of discrepancy here. But yeah, LP is a great idea. Anything else anybody would do?
You're in.
Yeah, you're in. Yeah, absolutely. All right, so I'm actually gonna pull up the MDM that they wrote for this patient. And I'm gonna have somebody read it if anyone wants to volunteer. I didn't want to put this on a slide because it would be too small, but I think it's important that we read through it to see like how this stuff kind of gets scrutinized in court. I'll move this up. All right, can anybody read this for me?
I can read it.
Awesome.
Says flu test was negative. He had a mono screen that was negative as well. He does not seem to have pneumonia. EKG showed sinus rhythm. Rate was 94 without significant dysrhythmia. CBC showed normal white count. Platelets were 61,000. I do not have any old to compare to. Electrolyte panel glucose was 275. Urine sample showed ketones and glucose. I sat and spoke with him at quite some length about the possibility that he may have diabetes. This should be followed up once he is not so ill. LFTs were normal, but I did have him go over for a lumbar puncture due to his body habitus. I had him do it through fluoroscopy. Fluid gram stain was negative for organisms. Gram stain seemed to have less than 5 nucleated cells on tube 3. Protein was elevated as well as glucose. I felt this leaned against any sort of bacterial involvement. I spoke to Dr. Blank on the oncology and arranged for follow-up for the patient for next Monday to have his blood counts, platelets rechecked. I thought this was suppressed due to a viral syndrome, but it sounds as if the patient may have had a problem with thrombocytopenia in the past. At this time, he does not show any purpura or petechial lesions. He does not appear acutely toxic. He seems to have improved after treatment here. The impression right now is viral meningitis and thrombocytopenia. He is to follow up with Dr. Blank in primary care here locally. I did discuss with him his hyperglycemia. He's to follow up concerning this, which has been arranged.
Thanks.
Discharge home routine.
Perfect. Yeah, so that's that. And so I guess I want to know, what are some thoughts on this MDM? The physician interpreted the EKG, chest x-ray labs, had a discussion about possible diabetes, got an LP done, interpreted that, discussed onc follow-up for the thrombocytopenia. So do you agree with this workup? Is there anything you would have done differently or documented differently?
I thought it was pretty good. Much better than the first one, but I mean, I guess shared decision making, but I don't usually discharge a viral meningitis.
Mhm. Yeah. Yeah, and I feel like viral meningitis, at least the ones that I've seen, usually these patients come in with like debilitating headaches to the point where they actually do need to get admitted and have like some further testing to see if it's something that can be treated versus just pain management. So I agree with that. When I read this, I think for me it would have been a reassessment and a discussion about the back pain, the red flag symptoms that they should look out for and come back for immediately. And if they can't get in to see their PCP, that they should come back to the ED regardless. Like he talked about all these other things. He talked about this onc follow-up and made sure that he sees that that person within 1 week because of a low platelet count with no signs of bleeding from any holes whatsoever. And then also talked about possibly having diabetes, which I think is an important discussion to have. But I feel like didn't address something that could have been emergent.
Yeah,
So
what
yeah,
bothers
tell
me
me.
is there's something bad underlying here, and I don't see where it's all put together. Um, just from a viral syndrome going on for weeks and weeks, and I would have kept this guy. I know a lot of people think I overdiagnose and I overtreat, but something is underlying this, and not because I know that there's going to be an M&M. There's just too many positives that are not explained, and there's something really bad underlying this. The other
Yeah.
thing is I've seen people burned by meningitis before, or CNS infections. This could be other things. For example, epidural. Now he's having back pain, early epidural abscess, other things.
Yeah.
I would have kept him and worked him up further, and I might have even covered him with antibiotics once I cultured him.
Yeah.
Was he ever on antibiotics PO before this?
No.
Okay.
Yeah. Absolutely, Dr. G. I totally agree with you. I think like hindsight is always 2020, but I think, I mean, you've also worked for many years where your spidey senses go off when you know that like something is not right and you're not addressing the entire problem. So I totally agree with that. Several days later, this patient returned to the same emergency department, and his primary symptoms seems now primarily to focus on back pain. It says spine pain, neck pain are both mentioned throughout the chart. Documentation reveals that the fever has now resolved, and he's been having a slight headache. The H&P were actually very well written. They were very thorough. The exam also included a back exam. There was no tenderness of the thoracic or L spine. There is tenderness of the paraspinals bilaterally, and the neck was supple. Can I have somebody else read this MDM? Anybody?
I can read it.
Thanks.
Hematocrit was 37.9. Platelets were 1,119,000 today. White count differential with some shifts to monocytes, 10% bands. Lactate was 1.3. Chemistries are remarkable for a glucose of 155. Calcium of 8. Total bilirubin of 1.9. Other liver functions are not remarkable. Repeat abdominal exam benign. Abdominal series is unremarkable. I recommend he keep follow up with the primary care. He has first appointment with a new primary care doctor on Thursday. He was prescribed some Percocet for pain, Soma for muscle relaxants, recent diagnosis of viral meningitis, thrombocytopenia, which is resolving, acute thoracic back pain, viral illness, old charts requested and reviews, nurses notes reviewed and noted.
Awesome. Thank you. Just to give you some context, this case happened in 2014 and was just kind of went through the system and like trial and everything ended years and years later. It's like 11 years later. So that's why there's Soma for muscle relaxants and Percocet for pain. So that was a patient's last visit before the bad outcome. This is his fourth visit for the illness. Is there anything else that anybody would have done differently so far, or any areas of documentation that you would have improved or changed, added on to?
I think like part of the problem is like they're just like repeating numbers
Yeah.
sometimes in the labs and not really like explaining their differential for why these things are happening.
Mhm.
And then just anchoring on viral meningitis. And then I don't know if in 2014 they had like biofire panels like like we do, but
Yeah.
if someone's febrile for 2 weeks and all these other things, like I would hope some cultures would have been drawn. There would have been some biofire that you're also following up on and saying, like, from last visit, like blood cultures are negative. This is negative. This is negative. Again, and I don't know, someone maybe I'm a scaredy cat, but someone with 10% bands, I'm not sending home.
No,
It's not happening.
yeah, I totally agree with you. I think that these are all some like red flags that need to definitely be addressed. And I also agree with you about I mean, I agree with you about everything, but especially the anchoring, right? This person now has this viral meningitis. So everybody's kind of like, oh, it's from the viral meningitis. It's from the viral meningitis. Without thinking about the possibility of having some concomitant infection or illness as well. So April 4th is the fourth ED visit now. And that morning, he developed new onset of weakness of the bilateral lower extremities. He also had sensory deficits. The physician ordered an MRI of the L spine to rule out cauda equina, and the MRI of the L spine was completely normal. So, given what you know now, what is the next step? Are we sending him home, back for primary care follow-up, ordering more tests, consultants, admitting? What would you do?
They only got the L spine. They didn't do the whole spine.
Yeah, correct. Yeah, Kyle, you tell him. So this patient was admitted to the hospital after the L spine MRI for the neuro symptoms. And in the hospital several hours later, an MRI of the T spine was ordered. And the MRI shows here that they have a ventral and left lateral thoracic spinal cord lesion, intramedullary or intradural extramedullary at the level of T9 and T10. Not completely characterized, but demonstrates mass effect on the cord. There's also an equivocal lesion of the dorsal extramedullary and intradural lesion at T7. They recommend an entire MRI of the spine, neurosurgical consult. So by the time that this came back, the patient's lower extremities seemed to have been completely paralyzed. The MRI shows a spinal cord lesion again that we discussed, and then they called neurosurgery. So during his hospital stay, the patient underwent a complete thoracic T7 to T9 laminectomy, a washout of an epidural abscess, and while they were in there, they noted osteomyelitis, discitis. The microbiology results showed MSSA, and unfortunately, the patient was left with flaccid paralysis and a sensory defect at T7 and was left with neurogenic bowel and bladder. Later in the hospital course, he developed septic arthritis in his right shoulder, taken to the operating room for a washout. Then he developed C. diff and was essentially discharged on an oral vanc in addition to all the other meds that he was on. So 2 weeks ago, this was a healthy 36-year-old male with some undiagnosed diabetes. He was on 0 medications, living an active 36-year-old lifestyle, and then was discharged from the hospital a few weeks later on 23 medications. That is, to me, a life changed forever. So the patient and his wife brought a lawsuit against both the doctors who saw the patient and discharged him from the ED. And there was initial discussion of a settlement, but the parties just couldn't agree. So a court date was set to go to trial. And during the trial, they ended up settling for hundreds of millions of dollars. I don't know the exact amount, but the case went on for years before this ended up happening. So I guess, how do we set ourselves up for success? Building good practices from residency instead of trying to figure it out on day one of attendinghood or after a lawsuit, I think is probably the best way to go about this. So there is actually a documentation rubric that lawyers will go through. And in court cases, you'll see them do this. The great thing is that if you document this way for all of your patients, your billing will also be covered because the billing and coding rubric includes a lot of these things. So together, we're going to go through the rubric that they use to break down the MDM for our patient. So the first thing, the brief overview, I actually cut this portion off in the MDM because it was just getting too long, but I thought the brief overview was totally fine. It just is like kind of like the 1 or 2 liner about the patient, their history, and what they're coming in with. So that's fine. And then in terms of the testing that's ordered follows a pretty natural differential, which we'll talk about the differential more. The results are clearly described, abnormalities are addressed for the most part. The rationale for what's ordered is good, and how it's interpreted is okay. The main issue, I think, is the interpretation of the results of the lumbar puncture that results in a diagnosis of viral meningitis. This is where the line blurs from the testing section to the differential section. The diagnosis of viral meningitis is somewhat of a soft call. The CSF shows a negative gram stain, a normal white blood cell count, elevated protein and glucose, which can be seen in normal CSF. So at this point, it's not impossible for the patient to have a diagnosis of viral meningitis, but I think it's definitely a stretch. In EM, we're allowed to discharge patients without a final cohesive diagnosis. And instead of discharging with the diagnosis, consider discharging your patient with a symptom. For example, right, a lot of times we'll write gastritis as a diagnosis, but if there isn't an endoscopy within the past 1 to 2 years in the EMR that shows gastritis, I actually go back and change the diagnosis that was put in by the resident to either dyspepsia or acute epigastric pain, because those are ICD-10 codes also. Or the gastroenteritis diagnosis, right? If you don't have a stool culture on the patient, we can't really say with 100% certainty that this is viral gastro or bacterial gastroenteritis. So I put vomiting and diarrhea or nausea and vomiting because those are ICD-10 codes. So giving this patient the final diagnosis when it's somewhat uncertain isn't actually necessary. Furthermore, it plants the idea in the head of the next doctor that could be really difficult to ignore. So we can help our colleagues by avoiding anchoring, setting them up for success, and make it more likely that they might catch something that we let slip through the cracks, or it just presented differently this time, because it causes serious damage otherwise if we don't use symptom-based discharge impressions, if we don't actually have a cohesive diagnosis. So how many points would you give this patient based on the testing? You have a 33% chance of getting it right, and it really doesn't matter.
2.
You give them a 2? Yeah. That's what they got. They got a 2 out of 3 for that. The next part for therapy. So the rationale for the therapy given was pretty logical. I thought there were a few odd things. One odd thing was that the patient was never listed as being nauseated, got Zofran. I think Dilaudid seems to be something pretty aggressive for a patient with multiple non-specific symptoms, including a headache, because as we know, opioids are a really poor choice for headaches. But unfortunately, it's still consistent with what many EDs around the country would do. A good thing is that he did document one reassessment. But oftentimes when we're working in a busy ED, we overlook documenting a reevaluation, even though we do it multiple times. Every time we walk past that patient, we either look at them, we look at the monitor, we talk to them, check in, but sometimes that doesn't always relay into our documentation. So documenting a second assessment and response to a treatment is a really critical part of defending your care, especially when there's no certain diagnosis. So for previous billing and coding, every time you reevaluate a patient and document it, it was supposed to have one subjective finding and at least one objective finding. So what I would do is say, hey, the patient reports feeling much better at this time, says his back pain is improved. That's the subjective part. And then I would put in my objective part. If he came in tachycardic, I would say the patient's heart rate is now improved. He's no longer tachycardic. Heart rate is in the 90s. And the patient has no midline spinal tenderness and no mild paraspinal hypertonicity in the thoracic area. So this way you're kind of covering yourself, even though this isn't necessary for current billing and coding. I think it makes sense, right? You give the subjective part, the part that the patient's telling you, and then how do you objectively document that they're feeling better? So my undifferentiated and unstable patients usually get the most reevaluations. So how many points would you give this documentation for therapy? Okay, I'm just gonna say it. All right, so the patient got 2 out of 3 for that. All right, so differential. As a general exercise, I think it's smart to include 3 diagnoses in the differential. This is also important for billing. So it's important for us to make an effort to include 3 emergency diagnoses that we do not want to miss based on the patient's presentation. Granted, there are some patients in which the differential is a lot less relevant. This is like if a patient has a shoulder dislocation or a laceration, you don't need 3 other differentials, right? The diagnosis is obvious. However, these cases are far and few between. And a common reason for a misdiagnosis is that just I never considered it. And we say to ourselves, there's literally nothing else this could be. And when we do that, we are setting ourselves up for failure sometimes. So documenting a 1-item differential is like obviously at our own risk, and sometimes it makes sense, but a lot of times it doesn't. So this patient had a good differential documented throughout. Overall, there was mention of flu, mono, pneumonia, dysrhythmia, diabetes, bacterial meningitis, viral meningitis, and viral syndrome. And then he had a thoughtful review of the abnormal labs, including the hyperglycemia and thrombocytopenia. So overall, this is okay, but there's multiple emergent conditions that are considered. One thing that obviously stands out is that a patient in back pain and fever should have considered spinal cord pathology. And there's really no mention of this aside from meningitis. So the points, they ended up getting a 5 out of 8 on their differentials. And for discrepancies, there's no point deduction, which is good. So unfortunately, the case didn't include nursing documentation as a part of the legal exhibits. So there's no way to tell if there's any discrepancies, but something that we need to keep in mind when we're documenting, if something goes against what was written in a nursing note or a triage note, make sure we say, contrary to the triage note, the patient is denying chest pain. He's reporting XYZ. If there are discrepancies, you actually lose points in the documentation rubric when they're like scrutinizing it. And then the aftercare portion, I think, is the biggest issue. So there's 3 main areas. There's plan of care, follow-up, and return precautions. So the patient documented that he sat and spoke with him at quite some length about the possibility that he might have diabetes. This should be followed up once he's not so ill. The fact that there's no documentation of a long discussion with the patient shows that the physician was thoughtful, he was kind. This might be seen favorably upon the jury, but the focus of the discussion is kind of inappropriate for the ED, right? Diagnosing type 2 diabetes is really important. But at the same time, there's an emergent life-threatening condition that left him paralyzed that wasn't further really talked about. So what else was I going to mention? So one positive note is that he did set up follow-up with a specialist. It's somewhat odd that it was a hem-onc doctor that was selected when he has this thrombocytopenia, which is kind of like a minor abnormality, especially in the setting of no bleeding. But it does show that the physician wasn't cavalier. He did actively consider a follow-up plan, but there's no plan in regards to medication, behavioral regimen, how to help manage the symptoms. And there's no instructions documented in regards to what you would need to experience or what symptoms you might have that should prompt you to come back to the ED. Yeah. So this patient received a 1 out of 4 for that. And essentially that leads to 13 out of 20, which is like a 65%, which isn't really great. So based on everything that you know, anybody having some reflections about their documentation, maybe you're doing amazing and you're doing all these things already. Maybe there's some things that you're like, I'm going to make sure that I write this in every note from now on, or the undifferentiated patients.
The thing you said about triage jumped out to me because I'm remembering several times where there's things that were written in triage when I talked to the patient that was not the case, or like half of it was true, but I just documented what I discussed with the patient. I didn't necessarily say like contrary to the triage notes. So I think that that's good to know that I could be writing that.
Yeah. Awesome. Thank you. Anything else?
I have a question for
Yeah.
the points in the differential. It said like
Yeah.
common complications. What does that mean? Like complications of a misdiagnosis?
Yeah, I guess it's like progression of disease mostly. Like if you're saying like, I think about it like when I'm writing, let's say like the patient might have, like if I was anchoring on this like diabetes thing, like maybe something to write in the note is like the patient is at high risk for an epidural abscess because they have this like undiagnosed history of diabetes that is like been untreated. They're having neck pain, back pain. Do you know what I mean? So you're kind of like discussing the risks that the patients have or like why they're high risk for something. It's kind of like when we do like our ACS stuff, right? Like
Yeah,
we
okay.
document our heart score, but it's more for what the outcome would be if the patient doesn't stay or doesn't get a stress, etc.
Okay, that makes sense. I think that I sometimes document my reassessment, but I think I could do a better consistently on all my patients.
Yeah, absolutely. Thank you. So again, the goals of documentation, there's a lot, but it really boils down to these three things: defensibility, continuity of care, and billing. It feels like when we aren't at the bedside, what we're doing isn't important, but I hope everyone understands that effectively documenting everything you did for your patient, why, your thought process, especially for the cases where we're uncertain and can't with 100% certainty say that this is a diagnosis, writing all of that down is equally as important to healthcare. So I just wanted to leave you with some pearls. Kelsey, start typing, please. So one, most disease processes are a dynamic process that patients can change from presentation throughout the ED course, through the dispo, and a lot might change. So it's important to do a lot of reassessments, to document and timestamp all of them for the undifferentiated and unstable patients. Two, you may do everything right and still get sued. And if your documentation is up to par, then the plaintiff has no leg to stand on. If the documentation isn't great, they will scrutinize every little thing to try to accumulate as many discrepancies to say that you didn't do a good job, even though that's not true. Three, this is my soapbox. Documentation is incredibly important, especially in the patients that we send home. We spend a lot of time giving our spiel to the abdominal pain patients we didn't scan, the back pain patients with difficulty walking, the headaches, the fevers with unknown origin. Take an hour one day just to write out dot phrases for that exact spiel that you give your patients. Use Dragon to do it. It makes it much quicker. Then all you have to do is add it into your chart whenever that patient comes in with the complaint, and you can fine tune the changes if your conversation diverges a little bit, if there's something additional you mentioned. This way, the process is pretty streamlined because you're doing this for all of your patients. So all you have to do is just put it in your chart, and you don't have to think about it very much. Lastly, hindsight is 20/20. This could happen to any of us. We see a lot of patients every single day, and it's easy to be like, oh, they're fine, I'm sending them home.